Hello, my name is Alba Azola, and I'm a physical medicine and rehabilitation specialist at Johns Hopkins. And I have the pleasure today to share with all of you our clinical approach to fatigue in long COVID and how implementing lessons learned from MECFS can be useful to help this new population of long COVID patients. I have nothing to disclose. And today we're going to go over some key areas of the subgroup of patients with long COVID that also meet criteria for MECFS. I wanted to go over the terminology. Earlier on, around 2021, the WHO coined the term post-COVID conditions, which they defined through a Delphi process into new symptoms that started 3 months from the onset of the SARS-CoV-2 infection, and that lasted at least 2 months and could not be explained by an alternative diagnosis. More recently, in June 11th of 2024, the National Academies of Science, Engineering, and Medicine released their definition, and they decided to use the term long COVID, and they defined it as an infection-associated chronic condition that has to be present for at least 3 months. So the symptoms have to be there for 3 months, but it can be continuous, relapsing, remitting, progressive, and that it affects multiple systems. Other terms that are used interchangeably are long haul COVID or post-acute sequela of SARS-CoV-2 infection or PASC. In terms of the characteristics of this new definition by NAM, it includes that there's no need for SARS-CoV-2 positive test to confirm the diagnosis of long COVID. So it can be a suspected or probable infection. The onset of duration, there's no set onset from the infection itself, recognizing that there can be a delay in the onset of symptoms, and they have to be present for at least 3 months, while the previous definitions range from 4 weeks to 8 weeks. This definition establishes 12 weeks as the point where we diagnose long COVID. It also establishes that there's no relationship between mild, severe, or acute, or mild or severe acute COVID in terms of determining whether the person has long COVID. So anybody that had COVID, either asymptomatic, mildly symptomatic, or severe, can develop long COVID. And it also establishes that this diagnosis can be made in people from different socioeconomic status, age, sex, gender, and that it can cause a severe functional impairment. So the RECOVER study from the NIH, the biggest US study, released about a year ago their findings on their approximately 10,000 subjects. And they found that there was a 10% prevalence of long COVID in those infected with SARS-CoV-2, and that reinfection and unvaccination were risk factors for developing long COVID. And they also identified 12 symptoms that, if scored, they can increase the likelihood of somebody being diagnosed with long COVID. This is not perfect. It was developed through biostatistics, and we need more studies confirming that this actually, what is the actual sensitivity and specificity of this scoring system. So it's not ready for clinical use yet. And now we're going to focus more on the fatigue piece after we had this overview of long COVID. And I want to start by establishing that not all fatigue is created equal. We may see patients that after a SARS-CoV-2 infection have post-infective or post-viral fatigue syndrome that persists for a few months, but slowly gets better. And when we also have people that had severe acute COVID and developed deconditioning and decreased endurance from that. But today we're going to be focusing on a special subgroup of patients with fatigue, those that exhibit uh, post-exertional malaise and chronic fatigue, and meet diagnostic criteria for chronic fatigue. So the key term here is post-exertional malaise, and it is one of the big features that is found in chronic fatigue syndrome, but it's also present in over 86% of patients with long COVID. And this is an exaggerated response and flare in symptoms after minimal activity that was easily tolerated prior to being infected. So patients present with severe exhaustion, muscle pains, worsening brain fog, sensitivity to light, headaches, migraines, sore throat, generalized malaise, feeling like they're coming down with the flu, changes in vision, tremors, heart racing. It can be a mix of some of the symptoms, but it's a rather exaggerated response to a minimal inciting activity. And the activity can be physical, it can be emotional, and it can be cognitive exertion that drives the presentation of these symptoms. Like I mentioned, there is established diagnosis for myalgic encephalomyelitis, chronic fatigue syndrome, and it requires a substantial impairment in activities that were well tolerated prior to the illness and that is present for more than 6 months. The presence of post-exertional malaise is required for diagnosis and unrefreshing sleep. And they can have either cognitive impairment and or orthostatic intolerance. So we can have a patient with long COVID that can be also additionally diagnosed with ME/CFS. And the approach to ME/CFS patients requires understanding of the common comorbidities present in this patient population. So, for example, we're going to be taking a look at all the factors that can be contributing to orthostatic intolerance, which is one of the main more treatable symptoms in chronic fatigue syndrome that can help improve their overall function, expand their energy envelope, and decrease the flare in symptoms. So we're going to start with looking at orthostatic intolerance. And back in the mid-1990s, our group at Hopkins and other groups as well started noticing this relationship between orthostatic intolerance and chronic fatigue, doing tilt tables and recognizing that many of these patients had reproduction of symptoms with standing, but they also had changes in the blood pressure and heart rate, sometimes dropping blood pressures, like in the case of neurally mediated hypotension, or also having an exaggerated tachycardic response, like in POTS. So what is happening in these patients? Basically, when they're in upright posture, there's an increase in pooling of the blood vessels in the extremities. And also, this population has a predisposition to have low intravascular volumes. This decreases the cerebral blood flow and sets off the alarm of a sympathoadrenal response that can manifest as orthostatic hypotension or neurally mediated hypotension, syncopal episodes, POTS. But also, we can have this decreased brain blood flow without and symptomatic reproduction with upright posture without changes in heart rate and blood pressure. So this is an example of a cheap version of the tilt test that we can do in our clinic with a 10-minute passive stand test, measuring heart rate and blood pressure response, but also looking at symptoms and the response to orthostatic challenge and the resolution of those symptoms once the patient is in supine position again. And I also wanted to highlight that other than the reproduction of symptoms, that patients can endorse, we can also see signs and symptoms. We can see flushing in the face. We can see acrocyanosis in the extremities. So it is a very useful clinical test. Now, what about those patients that have normal blood pressure and heart rate? They can actually, our colleagues from the Netherlands, Lisa van Kempen, has looked at internal carotid Doppler during tilt table, and the healthy controls demonstrate a drop of about 4% in cerebral blood flow on upright posture, while patients with ME/CFS post-COVID and POTS have a significant drop. And all three groups, so those with ME/CFS from COVID, those with ME/CFS prior to the pandemic or pre-pandemic with POTS, and even those with ME/CFS that have normal blood pressure and heart rate response during tilt table will demonstrate a vast increase in the reduction of cerebral blood flow. So this is an important point clinically, because we don't necessarily need to have that brisk tachycardia or that drop in blood pressure to start treatment, because we do know that even patients without that can have significant decreased blood flow, and they will benefit from volume expansion and other interventions. So this is a read of the Doppler, and you can see in a long COVID subject how there's a significant drop in blood flow at the internal carotid. And you can see compared to healthy controls where there's a minimal drop on the blood flow. And the interventions for orthostatic intolerance include hydration, salt intake. Other non-pharmacologic include like elevating the head of bed, cooling garments, autonomic rehabilitation, specialized physical therapy that can help increase blood volume and overall increases cardiac output. It is very important to understand that this cannot be a rigid advancement of graded exercise, and it needs to be tailored to the patient, not to exacerbate fatigue symptoms or post-exertional malaise. In terms of medications, we can separate them between vasoconstrictor, volume expanders, or things that mute that adrenergic surge or effect of the catecholamines that are circulating once we trigger that adrenal sympathetic response. So I have added a summary table with some common medications that we use in the setting, and you guys will have this available to look over. I'm going to move on to hypermobility spectrum disorders in this population. We have noted in our cohort a presence of EDS or hypermobile EDS or hypermobility spectrum disorders as a commonality or risk factor for these patients to develop long COVID or ME/CFS and also POTS. And this has been demonstrated by multiple groups, including Dr. Echo's group recently on the long COVID population. So it's important to screen them because this patient population will have other issues that need to be addressed that can be really helpful in decreasing the amount of fatigue. So screening with a Baton score can be helpful, not necessarily the end-all be-all, and there are more features that need to be taken into consideration for diagnosing hypermobility, but this is a good initial screener. There's also a lot of food intolerances, allergies, and mast cell activation syndrome. Treating mast cell activation syndrome and allergies can be very helpful in this patient population because a lot of the allergic responses will worsen the orthostatic intolerance. So what is mast cell activation syndrome? We know that in the COVID response during acute illness and also in long COVID, it's been hypothesized to be mediated by some of those chemokines released by mast cells. So exaggerated activation of mast cell can be part of that inflammatory response. And the symptoms that we'll see with this particular population is flushing, rapid heart rate, itching, swelling, abdominal cramps after eating, malaise, shortness of breath. Some people can have exacerbation of wheezing, sometimes elevation in temperature and body aches, kind of this muscle diffuse body ache. And the symptoms can be fluctuating and episodic. On physical exam, you can see sometimes the dermatographia, hives, redness in the neck and the facial areas. And treating these patients with initial interventions like H1, H2 blockers and other leukotriene inhibitors, for example, or mast cell stabilizers can be very helpful in not only those cutaneous manifestations, but really on the overall fatigue and orthostatic tolerance. We also look at vascular compression syndrome. Some of these patients have a higher predisposition, and it's been described in the POTS population as well, that they can have more pelvic congestion or other vascular compression. So in particular, iliac venous obstruction or May-Turner syndrome, it's associated with patients that have POTS. And hypermobility has also been associated with this type of pelvic vascular compression syndromes. And treating those can increase or can help symptoms of orthostatic intolerance. For example, this is pelvic congestion syndrome, and you can see kind of a vast network of blood vessels. Interventional radiology will place coils and decrease those vascular beds. And the patients actually have improved standing tolerance post-procedure. So definitely worth looking at. Another one of these vascular compression syndromes can be Eagle syndrome. This is compression of the jugular vein by an elongated or calcified stylohyoid ligament. And in this particular venous compression, patients can manifest with headaches, brain fog, dizziness, visual symptoms, and at times pulsatile tinnitus, styloidectomy, among other interventions, could be very helpful in decreasing that intracranial venous hypertension and decreasing symptoms. We have also observed craniocervical anomalies, including degeneration of disc causing compression into the spine, or for example, craniocervical instability. In this patient, for example, every time she was brushing her teeth, this would cause compression at the brainstem, and she would have episodes of syncope with activity that required head flexion. And addressing this obviously was really helpful. I also wanted to highlight that we do have 9 different multidisciplinary collaborative consensus guidance statements on evaluation and treatment of multiple symptoms of long COVID, including fatigue, autonomic dysfunction, cardiac manifestations, cognitive, etc. So I invite you guys to use these resources that have been together by plus 41 long COVID clinics with experience since the early pandemic, plus other providers that have been treating this patient population pre-pandemic, and it can be very helpful. And in conclusion, understanding and learning the lessons from clinicians treating ME/CFS prior to the pandemic has been very helpful in understanding an early implementation of interventions that can help these individuals improve their function, their quality of life. And if anybody has any questions, feel free to reach out to my email or via Twitter. Happy to answer any questions today, and have a beautiful day. Thank you so much for the opportunity to share with you. Bye.